3, 2, 1, live, sir. So we are live.
Yeah. Good evening. I think it is our third case in the series as one of the IRAS initiative, both to train the exam going residents and students, as well as the non-exam going postgraduates, even the practitioners who are otherwise face everyday examination from the patients. For them also, it will be helpful as a training modalities, how well we could approach the cases in day-to-day circumstances. To anchor this whole thing, I invite Dr. Shweta to take over. Dr. Shweta.
Thank you, sir. So it's my great honor to be here and to introduce our faculties. So we have Dr. Arul Murugan. He's one of the renowned rheumatologists from Madurai. And we have Dr. Dharmanand BG, who is a president, Indian Rheumatology Association and consultant rheumatologist, Manipal Hospital from Bangalore. Thank you. So over
Professor
to Dr.
Arul Murugan is a professor of rheumatology at Madras Medical College.
Oh, I shifted to Chennai, not in Madras.
Is a professor, HOD, director of rheumatology, Madras Medical College.
Yes.
Thank you, sir.
Okay. So I request Dr. Anjana to start the case presentation.
Good evening, respected teachers. Sir, is my slide visible?
Yes. Yes, sir.
Yes, sir. Can I start my presentation, sir?
Yes.
Myself, Dr. Anjana. I'm doing my residency in rheumatology at Manipal Hospital, Millers Road, Bangalore. Today, I'll be presenting arthritis case. Presenting to you Mr. A, age 29 years. He's an IT by professional, hailing from Bangalore. The date of examination was on 8th of December, 22. So Mr. A presented to our OPD with the following complaints, that is pain and swelling of both the ankles and forefoot since 4 months, pain and swelling of both the knees since 4 months, left-sided unilateral gluteal pain since 4 months, rash over the scalp, feet and umbilicus since 4 months, and deformed nails since 4 months. Though most of the symptoms started at 4 months, there was a discrepancy of around 1 or 2 weeks between the onset of joint pains and the onset of rash. Presenting to history of presenting illness. Patient was apparently normal, healthy male 4 months ago. He noticed pain in both his ankles and forefoot 4 months, which was insidious in onset, gradually progressive, and asymmetrical, that is left more than the right. The pain was continuous and vague in nature. There was no radiation or referred pain, which was precipitated by activities such as walking and prolonged standing with minimal or almost no relief of pain with rest, and he had significant relief of pain with medications, that is NSAIDs. Along with the pain, he also noticed swelling in both the ankles and forefoot since 4 months, which was insidious in onset and progressive. There were no diurnal variations. There were no precipitating or relieving factors for the swelling. Similarly, there was pain in bilateral knees, right more than the left, which was gradually progressive. A similar type of pain which was seen in the ankle and forefoot, which was precipitated by activity and very minimal relief with rest and significant relief with NSAIDs. There was a history of early morning stiffness in both the ankles and the knees, which lasted only for 20 minutes. Left-sided gluteal pain since 4 months, progressive in the form that there was increase in intensity of pain. The episodes became more frequent, usually in the early mornings associated with stiffness for 20 minutes. And the stiffness was more when he was sedentary, that is with prolonged sitting. It got better with activity and exercise with relief with NSAIDs.
Why do you say it's episodic? What do you mean by episodic carpal pain?
I meant to say that the pain was more with rest, sir, and it got better throughout the day as he progressed with his day-to-day activities.
Is it called episodic?
No, sir.
We don't call it as episodic.
Yes, sir.
Maybe they can have early morning stiffness. That's okay. But it's obvious that inflammatory back pain gets better during activity. That doesn't mean the pain is episodic.
Yes, sir.
So, when do you have episodic pain and swelling of joints? What are the diseases that can present with episodic pain and swelling of joints?
Like palindromic rheumatism, where the episodes are isolated by clinically normal periods.
Yes. What are the commonly involved joints in palindromic rheumatism?
So it's predominantly the lower limbs, and the larger joints are most commonly involved.
Is it so? What's the typical presentation of palindromic rheumatism? How does it present? How the patients will come and tell you about that?
Sudden onset of severe intensity pains and signs of inflammation.
Over the joints, do they have any erythema over the joints?
Yes, sir. Yes, sir. There is scalar rubor and pain also, tenderness, and the joint pains are isolated in episodes, sir.
It commonly involves the hand joints. Palindromic rheumatism commonly involves the hand joints.
Yes,
if by episodic arthritis involve the lower limb joints, what are the things you will suspect?
Particularly in a young male.
Reactive arthritis.
Yes.
Is it really episodic reactive arthritis?
Reactive arthritis is not a single disease which has episodic.
Ideally, it is not episodic, sir. But
what else can cause episodic pain predominantly in the lower limbs in a male? If there's a family history, strong family history also.
Psoriatic arthritis.
What about gout?
Yes, sir.
So what is the typical presentation of gout?
Commonly involves the first MTP followed by the ankle. Sudden onset of severe pain associated with swelling and erythema.
And lasts how long? Is it self-limiting or is it
most of the times in 70 to 80% of patients, the first episode is self-limiting, sir. It begins. It progresses overnight. That is, as soon as the patient gets up, the first thing he notices in the morning is a painful swollen toe.
And apart from first MTP, which is the second most common joint?
Ankle joint is involved. Is the second most common.
Midfoot. Midfoot is more common than ankle.
Yes, sir.
So what about acute rheumatic fever?
Sir,
episodic arthritis or rheumatic fever?
Migratory.
No, it is the episodic arthritis or not?
It is episodic. It is episodic, sir.
Which disease? What are the diseases present with bilateral ankle arthritis predominantly? When somebody comes with bilateral ankle arthritis.
Yes, sir. Sarcoidosis.
Yes.
A symmetric rheumatoid also can be a differential.
Right.
Predominantly.
Next is Henoch-Schönlein papilla. HSP
Yes,
or
HSP.
arthritis.
Yes.
Both these things can present bilateral ankle
Yes.
arthritis. In a male, young male, is there any other condition which mimics arthritis which can occur in episodes, which has to be ruled out? Patient comes with severe pain and the signs of inflammation, but it's not strictly an arthritis. Hemarthrosis
Cellulitis.
in a male, he
Yes,
comes
sir.
with hemarthrosis. Which disease you are supposed to rule out?
Hemophilia, sir. Hemophilia.
Yes, that occurs in episodes. No?
Yes, sir.
Recurrent episodes of knee swelling in a young male is a suspect. Rule out
Hemophilic
hemarthrosis.
arthropathy.
Yeah.
Yes.
Not hemophilic arthropathy, hemarthrosis. Hemophilic arthropathy is different. Yes. Go on.
Yes.
Continue your presentation. Yes.
The left gluteal pain, unilateral, since 4 months. Most of the characters fit into inflammatory back pain with early morning stiffness lasting for 20 minutes and relieved with exercise and NSAIDs.
What does the criteria say? Well, duration of early morning stiffness.
Yes, sir. The onset 3 months, age less than 45 years. With the pain exacerbates while the patient is sedentary. It improves with exercise, and early morning awakening at the second half of the night.
Right. What's the duration of stiffness usually in inflammatory?
30 minutes, sir. More than 30 minutes.
1 hour at least. It will last for 1 hour for back pain.
Yes.
Yes. Yes.
Rash over the scalp, foot, and the umbilicus since 4 months. The rash was predominantly over the back of the head, which was dry, itchy, and patchy, associated with some hair loss. And from the rash, there were white powdery scales over the scalp, which improved with some topical preparations. The rash was not painful. There was no pustular discharge or bleeding from the rash, and no similar rash elsewhere. The
So
patient
what
also,
do you think this probably is? The rash.
I would first think about psoriasis.
Yes. Anything else?
Seborrheic dermatitis.
Yes.
Seborrhea.
Yes. Any other disease which can present with hair loss and skin lesions?
Lupus, alopecia areata can present, but the rashes won't be itchy most of the time. So.
Right. Lupus, can you have psoriasiform lesions in lupus?
Yes, sir. Psoriasiform dermatitis.
Dermatitis, which is the area, commonly involved area in psoriasiform lesions or subacute cutaneous lupus.
SCL.
Is it scalp? Scalp, is it commonly involved or any other part of the SCL?
Usually it's the face more than the scalp, and skin and mucosal are more common than the scalp.
Face, is it commonly involved in ACLE or ACL? Subacute cutaneous lupus.
Dr. Murugan is asking about subacute cutaneous.
Yeah, psoriasiform lesions. We are talking about psoriasiform lesions. It's one of the ACLE, subacute cutaneous lupus lesion. Where do you see commonly?
In acute, the butterfly rash is more common.
No, subacute cutaneous lupus erythematosus, SCLE. What are the types of lesions in SCLE? One is psoriasiform lesion. Another, one more lesion.
Yes, they begin as plaque-like lesions, but they are more dense and thicker than the normal. So when compared to the normal psoriatic rash, and they'll not have the characteristic that Auspitz sign or Cognos phenomenon.
No. What's the area commonly involved? I mean, this SCLE is more photosensitive rash, so it occurs over the exposed areas, back and extensor aspects of the forearm. One is psoriasiform lesion, or next another is annular polycyclic lesion. So these are the two types of subacute cutaneous lupus lesions. When they have alopecia and the scarring and plaque, you suspect DLE. That's more common.
Discoid lupus. That is the site for discoid.
Common in scalp.
Yes.
Yes, go on.
The rash was not associated with pain or pustular discharge or bleeding. Patient also noticed deformed nails since 4 months, predominantly the fingers than the toes, which did not have any discharge or pigmentation, and no associated pain.
How can you say even the nail changes or nail, what do you say, nail deformity?
Deformity of the nails.
What do you mean by deformed nails?
He noticed that his nails were becoming thick, and he also told that it was difficult for him to cut his nails. They were becoming thick.
So he has noticed only at the time of joint pain and skin rash.
Yes, sir.
What are the nail deformities, nail changes? Means you will see in dermatological illnesses.
One is pitting of the nails,
right?
Onycholysis.
When it's significant, nail pitting. When will it give significance to the nail pitting?
More than 60 is it significant, sir?
More than 60. Just the reference for your answer. Do you have any reference for that? More than 60.
No, I think
two per nail, totally 20. That itself is enough. Yes. What are the other nail abnormalities?
Onycholysis.
Yes.
Subungual hyperkeratosis is seen. Onychomedesis is also a feature, sir.
Feature of which disease?
Psoriasis. All these are.
Any other disease which can have nail changes? What about reactive arthritis? Can you have nail changes and reactive arthritis? What nail changes occur in SLE? So
most of it,
hypertrophy and onycholysis can occur even in reactive arthritis. In SLE, you will have dyschromic nails.
yes.
Yes. Correct.
The patient also told us that he had significant pain relief. Initially, he was given a trial of NSAIDs and oral steroid medications elsewhere. But after stopping these medications, he had recurrence of symptoms. Coming to negative history, there was no neck pain, no restricted movements of the neck or the back noticed by the patient, no significant pain in any of the other joints, no symptoms suggestive of any inflammation in the eye or the bowel, no urethral discharge or genital ulcers, absence of constitutional symptoms such as weight loss, loss of appetite, and fever. The patient does not report any similar history in the past, and he did not have any comorbid illness. No such history in other family members in any of the first degree relatives. Summarizing my history, a young male with no comorbidities presenting as asymmetric polyarthritis with early morning stiffness and inflammatory left gluteal pain with skin and nail involvement, all these from the past 4 months, and not accompanied by any significant family history.
What's the DDs you can offer in this case?
Yes, sir. I would like to think about psoriatic arthritis as my first DD, followed by reactive arthritis.
So it is a reactive arthritis. What are the clues that the patient might have?
Yes, sir.
Clues?
Predominantly, most of the involved joints are of the lower limbs, and the larger joints, that is the knees and the ankles, are most of his symptoms. He also had history of rash, though it is more consistent with psoriasis.
How will you differentiate? How will you differentiate? What's the skin lesion you mean? Skin lesion
Yes, sir.
in reactive arthritis.
Reactive
psoriasis.
Yes, sir. Keratoderma blennorrhagica is a very close DD to pustular palmoplantar psoriasis. And even erythrodermic lesions also can be seen less frequently in both of them. So.
What is the other typical skin feature of reactive arthritis treaters?
Succinate balanitis.
Yes.
Succinate balanitis with very less frequently the patients recall any preceding episodes of infection like urethritis, cervicitis, or URTI or genital.
Yeah. So if the patient is not able to recollect a typical infective episode few weeks before his onset, is there anything else from the history which might give you a clue that it could be a reactive arthritis? Patient's history, particularly any ocular symptoms, if it is associated at the onset.
It can present as acute anterior uveitis. It can be a present.
Not reactive
arthritis. You mean in reactive arthritis, patient presents with acute anterior uveitis? Which one is commonly seen in the Pentards?
At onset of the disease, patients may have redness in the eye. Due to what? Not uveitis. What else it can occur? What can cause?
Conjunctivitis.
What is Redditor's triad?
Yes, sir. Urethritis, conjunctivitis, and arthritis.
Yes. So that is the one clue for you. If there is patient complains that my eyes became little red, not painlessly red and little sticky, that could be the clue. So if the redness is little pinkish red, it's not severely red like what we see in uveitis or scleritis, and it is generally non-itchy. It is sticky. This is very typical of the days at onset. If they have this symptom, then that suggests that patient might have reactive arthritis. So that's an important clue. It's not uncommon. If you ask for it, you will get it.
Can you have conjunctivitis in psoriatic arthritis?
It can be a presenting feature, sir.
May not be a presenting feature. You can get both uveitis and conjunctivitis in psoriatic arthritis.
Blepharitis, conjunctivitis, all can occur with psoriatic arthritis, psoriasis.
Yes. What's the clinical history you will elicit for ruling out uveitis to differentiate from conjunctivitis?
Presence of photophobia.
Good.
Excessive tearing from the eye.
Why excessive tearing? Photophobia, yes.
in
Somebody gets a uveitis, photophobia, I agree. What else the patient would complain of?
presence of patient may have floaters and presence of floaters, sir.
Patient floater, blurring of vision,
Blurring. That's an
Yes.
important sign.
blurring of vision, as if he is seeing through a screen of smoke. So smoky vision, large number of floater, they are all clue. And redness will be around the circumcorneal edema rather than a diffuse edema. So these are the clues from the history, and if it is self-limiting or got better with X number of days of some drops, this would be the clue for a reactive uveitis in a patient with this kind of a spondyloarthritis. You should be able to differentiate from history suggestive of conjunctivitis, scleritis from the history itself. Which will be painful, scleritis or uveitis?
Scleritis, sir.
Scleritis can be very painful, even can cause entire headache, entire that side of the eye and the head can ache. So scleritis can be very painful, but uveitis is not very painful.
Painless.
Can it be gout?
Polyarticular gout, it is not very often seen, and 4 months is a very long history for gout, sir. And he doesn't give any history of that dramatic sudden onset pain with a lot of inflammatory changes.
You have to tell it such a way that patient did not have past history of self-limiting episodes of joint pain involving the lower limb.
Yes.
That is how we have to answer, right? So patient, what you have looked for is a past history of self-limiting episodes of features suggestive of acute gout. Then the cat can be dramatically painful, but that is how we don't describe it. Self-limiting episodes of arthritis affecting the lower limb, predominantly lower limb joint. That history is not there. This patient has more persistent arthritis, subacute onset persistent. So that makes gout less likely. You have to argue like that.
Yes.
Did you ask for any exposure to STD history in this patient?
Sir,
Exposure history
to sexually transmitted diseases.
No, sir.
Is he married or unmarried?
Patient is married, sir.
If it is married, how will you ask the question? If you ask whether the sexual exposure, he's going to say if he's a married man.
Whether any similar symptoms in the partner?
That can be one. And another one is, has he had any new sexual partner in the recent past? Did he have an unprotected relationship with anybody who is not his wife? So this could be clue. People don't always reveal. We have to ask.
Yes.
When do you suspect HIV in this individual type of arthritis? Is there any clue that I can suspect HIV? Any
constitutional symptoms like fever, night sweats, weight loss, loss of appetite, generalized lymphadenopathy?
No, anything else? If you are suspecting psoriatic arthritis. In psoriatic arthritis, will you suspect underlying HIV in any situation?
The psoriasis in HIV is mild or severe?
It is mild, sir.
Mild in HIV? It's extensive.
When that's what Sar is asking. When somebody has an extensive psoriasis, think of HIV as a potential underlying cause in a psoriatic arthritis patient.
In reactive arthritis, if they have keratoderma planoregica, always ruled out HIV.
Yes, sir.
Yes.
Okay, go ahead with the examination.
Yes. Coming to general physical examination, well-built young male, conscious, cooperative. The scalp had patchy plaque plaque-like lesions, or the most of it, or the posterior aspect, along with silvery white scales. Though there were no bleeding spots on the plaque-like lesion. The nails of the fingers and the toes had characteristic subungual hyperkeratosis with transverse grooves over the nail plate, and onycholytic changes also were seen. But
He has
no.
dyschromic nails also. He has dyschromic nails. Psoriasis is another cause for dyschromic nails.
Yes, sir. No pits were observed. Asymmetric swelling of the ankles, that is the right more than the left, along with swelling of the dorsum of the right foot, suggestive of synovitis, and also associated with tenderness and a non-pitting. Also, the right fourth toe was swollen. The entire toe was swollen, suggestive of dactylitis, along with a few other nail changes which can be seen in the picture.
What is dactylitis?
Inflammation and inflammation of the entire digit in total, sir.
What do you mean by
So that
inflammation of entire digit?
it
What
it
are the
is
structures are inflamed? What's underlying pathology?
Yes, sir. Most commonly, the entire digit of either the finger or the toe is swollen, so that it's difficult to appreciate the interphalangeal joint.
That's okay. Whether arthritis gives rise to this appearance or anything else
No,
done
sir.
with arthritis.
Along with arthritis, there is involvement of the tenosynovium and the
Tenosynovium.
subcutaneous tissue.
Yes.
Yes, sir.
Yes.
Also, in his both foot or the plantar region, there were healed hyperpigmented scaly lesions, which is suggestive of possible plantar psoriasis. Similar lesions suggestive of umbilical psoriasis were also seen, with few scaly hyperpigmented lesions over the abdomen.
Are there any pustules over the abdomen? What's that lesion? I could see some lesion like a pustule below the umbilicus.
It was
Lower
the
abdomen. Lower abdomen. Is it a pustule or?
No, sir. It was there were no pustular psoriatic lesions. It was a folliculitis, sir. It wasn't a psoriatic.
Right. Young male presenting with pustules, tenosynovitis, arthritis, migratory arthritis. What will you suspect?
If it is a female, menstruating female, similar picture, tenosynovitis, pustules, and acute arthritis, plus or minus urethritis.
Can it be?
What is BGI?
Sir?
What is BGI? BGI. Right. Disseminated gonococcal infection.
Okay, sir. Yes.
Gonococcus can cause arthritis, tenosynovitis, acute red swelling over wrist is particularly preferred. You can have pustules over the wrist or any other part of the body, and urethritis may or may not be symptomatic, particularly in women. So we have to get a urethral smear, and we have to suspect this. This used to melt with penicillin, and it's very rarely seen nowadays. But if the disease comes back in the near future, probably we would miss because we are not going to suspect it. So we have to keep some of the classical causes for arthritis, and if it makes a recurrence, then we'll all have a problem, because the current generation of pediatricians have not seen a whooping cough. If somebody comes with a whooping cough, nobody knows because there is no reference for that. So we should not forget some of the classic cases, because gonococcus might come back with increase in promiscuity and other reasons, social reasons.
Yes.
Yes.
Proceed.
General physical examination was normal. Vital signs were stable. His BMI was 29 kg per meter square. Coming to musculoskeletal examination of the ankle and the foot. On inspection, there was a diffuse swelling over the anterior, medial, and lateral aspect of both the ankles, the right more than the left. Similarly, over the forefoot and also the midfoot dorsum. As showed in the pictures earlier, there was dactylitis of the right forefoot. The posterior aspect of the foot was normal bilaterally. There were healed psoriatic patches over the plantar aspect. Nail changes, that is subungual hyperkeratosis in most of the nails. There were no other deformities or callosities. On palpation, there was a mild increase in local temperature over the ankle, midfoot, and forefoot over the right limb. Synovitis of bilateral ankles, and there was tenderness over the midfoot, that over the mid-tarsal joints, and over the second, third, and the fourth MTP joints on the right side.
How do you say you have patient has synovitis around the ankles? How did you conclude that it is synovitis, not synovitis around the ankle?
Sir, most of the swelling would be on the anterior aspect of the ankle and the medial aspect, sir.
And apart
Most
from
of it on the anterior.
Apart from that, anything else? Which movements will be restricted? Which movement will be painful if the ankle is involved?
If the ankle is involved, then dorsiflexion and plantar flexion, sir.
Yes. So did the patient have that?
Yes, sir. He had movements.
Okay.
I'll be telling later.
Yeah.
In my upcoming slides.
In this description, you should say that patient has got swelling in the ankle, particularly in the anterior-medial aspect. That would be a better way of presenting.
Yes,
because
sir.
synovitis is a more a histopathological diagnosis.
Okay, sir.
Right? Clinically, patient has bilateral ankle, and if the ankle movements support the diagnosis of ankle involvement, then you can conclude that patient has ankle arthritis. But from palpation and inspection, you can't say it is synovitis.
Yes, sir.
Okay. Go ahead.
Yes, sir. Movements of the right ankle, both dorsiflexion and plantar flexion, were terminally restricted and painful. The left ankle movements were normal, but they were painful. Subtalar joints, inversion and eversion, were normal in both the foot. Right mid-tarsal joints, there was painful inversion and eversion, and right MTP squeeze showed tenderness. The right first to fifth MTP joints were painful with dorsiflexion and plantar flexion restricted. Right fourth toe had dactylitis, so the movements were restricted and painful. Other PIPs and DIPs were normal, and the rest of the joints on the left foot were completely normal. And there was no deformity or tenderness over the Achilles tendon insertion. Coming to the knee examination, swelling noted around both the knees, but it was asymmetrical, right more than the left. There was mild local raise of temperature with few signs suggestive of effusion on the knee. That is balloon sign, and patellar tap was positive on the right with tenderness. Movements, the flexion was normal, but there was a terminal lag of 5 degrees with extension of the right knee.
Which
knee,
disease presents with swelling disproportionate to pain, especially in the knees? pain is less, swelling is more. Huge swelling with less pain. Especially in our part of
The question is, which condition can cause a big swelling in the knee with not much of
without
pain?
pain. Yes. Any infections which is prevalent in our so monarch. Yes.
Tuberculosis.
Tuberculosis. Which disease presents with pain disproportionate to swelling?
Septic arthritis.
It's common in children.
Hemarthrosis of the knee.
Children sitting with a lot of pain in the bony areas, but not much of a swelling.
Acute leukemia.
So I was talking about leukemia.
Acute leukemia. Yes, acute leukemia. The person with severe pain without much swelling.
Yes.
Yes.
The left knee had mild to moderate effusion with the bulge sign positive, with normal movements and no deformity. Bilateral hips were normal. The left sacroiliac joint was positive for when the Faber test was performed. Distraction and compression test were normal, and the right SIJ was normal. Other joint examination of the upper limbs were normal. Both the cervical spine and the lumbosacral spine examination were normal, where the tests performed were modified Schober's chest expansion of 5 centimeters. The lateral flexion was normal on both the sides, with no or zero distance between the occiput and the wall. Systemic examination of all the 4 systems were normal, with no findings remarkable.
What do you see in the cardiovascular system? What do you expect in patients with arthritis? Arthritis like this patient, asymmetric arthritis, lower limb arthritis. Which cardiac manifestation are you expect?
Seronegative spondyloarthropathies can present with aortic valve abnormalities, sir. Aortic.
Which spondyloarthropathy can cause AR in a short period like this, 4 months period? Reactive arthritis. Reactive arthritis can cause AR.
Yes.
Yes, Rob.
So at the end of my case and clinical findings, I would like to conclude it as psoriatic arthritis predominantly involving the peripheral joints with a swollen joint count of 30.
You said there is sacroiliac joint involvement.
Yes, sir. But I'll be telling the other findings in my upcoming slides. Why I told only about the periphery.
Psoriatic arthritis. What are the types of psoriatic arthritis? Usually, yes. What are the descriptions?
Asymmetric oligoarthritis, symmetric polyarthritis, dactylitis predominant variant, axial involvement.
And arthritis mutilans.
Yes, sir. Or arthritis mutilans, deforming psoriatic arthritis.
What is the commonest type?
The commonest type is asymmetric oligoarticular presentations.
Right, yes, go on.
Yes.
What was the original description by Nolan, right? Which type was communist?
Yeah.
The original description says polyarticularis. We have done a study which showed oligoarticular as the commonest one. Yes, sir.
Yes.
Go on.
Yes. So on investigation, hemoglobin, blood counts, and platelets were normal. ESR and CRP were markedly elevated with 52 and 92.3 milligram per liter. Other routine investigations like liver functions and renal functions were normal. Though it was a characteristic presentation of psoriatic arthritis, patient came with antibodies which was done elsewhere, which were negative. Urine
Can
examination.
you have RF positive in psoriatic arthritis?
Yes, sir. But it is one of the criteria which doesn't fit into the Casper. One of the entity which should be negative when we classify.
Okay. As per criteria, you should have negative RF. But can you have RF positive in psoriatic arthritis? If so, how it presents? RF positive, is it low titer, high titer positive?
Ideally, low titer rheumatoid factor positive, sir.
Can you
Because-
have ANA positive in psoriatic arthritis?
Yes, sir. Because around 5% of normal individuals can have low titer ANA positivity. So he can be one of them who has these antibodies.
What percentage of a normal population has psoriasis?
Around 7, according to Indian articles, around 17 to 40% is the range, sir.
No. Psoriasis in a population.
Population.
General population.
Oh,
How common is psoriasis?
1%, sir.
Yeah,
Global
even 1 to 2% is
2%.
so
2%.
1 to 2%. So you will have enough psoriatic patients with low titer ANA positivity, low titer rheumatoid factor positivity, and psoriasis and rheumatoid arthritis both being common. There may be patients with rheumatoid arthritis with psoriasis and psoriatic arthritis with rheumatoid factor positivity. All these combinations can occur. So we have to make our diagnosis based on the phenotype.
clinical.
Which
Yes.
phenotype will make you suspect somebody with a lot of joints are involved? Rheumatoid factor is positive, moderate titer, and patient also has psoriasis. Which are the features which will make you suspect that the patient has psoriatic arthritis?
Predominant lower limb involvement and asymmetry.
Patient has polyarthritis. For example, patient has polyarthritis mimicking rheumatoid. What are the
Yes.
other features you will look for to ascertain that it's psoriatic arthritis?
Other features that particularly occur in psoriasis is dactylitis and enthesitis, which are very less commonly in rheumatoid.
Yes. Then
That will be the clinching feature. Presence of, once you make out a dactylitis, that becomes less likely that it is rheumatoid. That is more likely to be
Psoriatic.
anything else? Anything else?
Axial involvement in terms
Yes.
of sacroiliac joint goes
Yes.
more in favor of psoriatic rather than rheumatoid.
yeah. There are other clues. Yes.
And characteristic deformity like opera hand, involvement of DIP is classical of psoriasis. And in rheumatoid, it is more of the MCPs and PIPs rather than the DIP.
Yes. Good.
What are the diseases you can diagnose with pattern of joint involvement?
Sir, diseases?
Pattern of joint involvement. There are particular joints are involved, or some diseases have predilection for some joints.
Yes, sir. Yes, sir.
So what are those diseases?
Rheumatoid, osteoarthritis, more of first CMC and cervical spine. Rheumatoid.
Why cervical spine? In the hands. They are
Joint-
worried about somebody coming with hand. First CMC and which are the joints in hand?
First CMC and wrist. Wrist is commonly.
Wrist
Can
is
be
affected.
Spare. Wrist is
Wrist is
typically
spare.
spare in osteoarthritis.
A combination of distal interphalangeal joint, proximal interphalangeal joint, first CMC. This combination is osteoarthritis.
Yes, sir.
Burden's nodes, Bouchard nodes, and first CMC OA. This is very typical of OA. Because a spotter.
Yes, sir.
Wrist is not involved unless there is a injury.
Secondary.
Primary osteoarthritis is not common in wrist.
Yes, sir.
Which are the other joints? Primary OA is not common.
Ankle and shoulder are not commonly involved.
Shoulder is common. Elbow is not common. Shoulder acromioclavicular joint is probably as common as knee.
Yes, sir.
Acromioclavicular joint osteoarthritis is almost as common as knee, second or first most prevalent joint for OA.
Which type of population you get ankle joint degenerative arthritis of the ankle joints?
Sarcoidosis, sir. Ankle synovitis.
Degenerative arthritis of ankle joints. Ankle OA is very rare.
If
But
you see
this
ankle OA,
this
what do you
particular
think?
group of people will develop ankle. Have more chances of developing ankle.
Second, patient who has RA could develop secondary
no
OA.
RA, no RA, primary osteoarthritis.
Crystal arthropathies is a possibility, sir.
When it becomes a secondary, no? There is an underlying primary disease, it becomes a secondary way. So I am asking about primary way, without any other underlying any rheumatic disease, inflammatory. Any sports, recreation related events that can predispose ankle OA. More common in dancers, especially ballet dancers, ankle OA can.
In deltoid ligament injury.
No, dancers, dancing professionals, especially ballet dancers,
Yes, sir.
they are more prone for ankle. Yes.
Yes.
go ahead.
Yes, sir. X-ray pelvis was done, which showed normal bilateral SIGs and hip joints. So, with the diagnosis of psoriatic arthritis, predominantly involving the peripheral
Did you
joints.
do MRI or not? MRI for sacroiliac joints.
MRI,
If
we
X-ray is
advise.
normal, can you say SIJ is normal?
Yes, sir. MRI was advised, but since the patient was not willing, we could not do it, sir.
Yes.
Will it help MRI?
Yes, sir. It will help, sir. It can still be non-radiographic seronegative spondyloarthritis.
How long it takes before clinical sacroiliitis to be visible in an X-ray?
Are you asking about the time lag, sir? Or
Yes,
the
time
amount
duration. Yes.
of, 4 to 7 years.
It takes many years, sometimes even 7-8 years. So it takes a long time. So we need an MRI to document. Okay,
Yes,
this patient, you did an MRI. MRI is totally normal sacroiliac joint. Then what would you think? What would you ask radiologist to look for, and what are the other possibilities? The MRI is totally normal, like no sacroiliitis. Would you ask radiologist to look for something? Would you go to the radiology department and ask them to look for something?
Both, if there are any changes like erosions, fat metaplasia.
No, that is sacroiliac joints are normal. Sacroiliac joints are normal here. If it is normal, would you look for other things. What are the other things which can happen in psoriatic arthritis in and around the pelvic bones?
Hip involvement can be there, sir.
It will be obviously seen, no? It is reported as normal. You should look for enthesial. Enthesial involvement of subtle enthesial involvement will be missed in a cursory look by the radiologist. We have to go ask them to look for entheses around the sacroiliac joints, around the pelvis, around the enthesial points, ischial tuberosity, etc. If they are also normal, then you should go back to his profession. He's an IT professional sitting for most of the time. Then you should start looking for other causes, soft tissue rheumatism, other myofascial pain syndrome, etc.
Yes.
Okay. Okay. So how will you treat this patient? How did you treat the patient? How will you treat the patient?
Yes. With the diagnosis of psoriatic arthritis involving predominantly the peripheral joints, we chose methotrexate to start with, along with folic acid and NSAIDs SOS for arthralgia.
Why it's for arthralgia alone? Any other use of giving NSAIDs?
NSAIDs
only is
also
it an analgesic or
no,
can
sir.
have
It also
anti-inflammatory?
has a role in reducing radiographic progression over.
It's an anti-inflammatory. It's a non-steroidal anti-inflammatory drug. So it can bring down even the inflammation. That's why initially NSAIDs are tried in psoriatic arthritis. How long will you give an NSAID to have anti-inflammatory effect? What's the minimum period required for any NSAID to give anti-inflammatory effect?
Any NSAIDs maximum tolerated dose to be tried
What's
for
the duration? What's the duration? Minimum duration you have to try.
4 to 6 weeks, sir.
For anti-inflammatory effect. That's for telling about the treatment. So this is for anti-inflammatory effect. So minimum you should give for 2 weeks to see the anti-inflammatory effect. Otherwise, it won't have any anti-inflammatory.
Okay.
Yes.
Anjana, we have reached a time limit. Can you summarize now? You told the treatment, but anything else you want to tell?
When will you try biologics in this case? Patient has got peripheral arthritis.
Yes, sir.
Any other factors will influence you to start biologics?
Disease activity, that is progression of symptoms, involvement of new joints in spite of being on methotrexate, and inflammatory markers like ESR and CRP I would consider. After optimal duration of around 8 to 12 weeks.
What are the factors that will tell you that patient has got severe disease? Is there any criteria for that?
Yes, sir. There are severity scores like PASI, PASTAS, and clinical disease activity in psoriasis index.
Yes.
The components of when minimal disease activity attainment is difficult with conventional synthetic DMARDs, then I would consider escalating treatment to biologicals.
Is there any situation where you will think of biological straight away? Is there any? See, there are many domains in psoriasis, psoriatic arthritis.
Yes, sir.
If somebody has certain features, you know that your conventional DMARDs are not going to work. You would suggest either a biologicals or a JAK inhibitor straight away. What are the features?
Axial involvement, predominant dactylitis and enthesitis, because these factors don't improve with conventional synthetic DMARDs, sir.
Dactylitis may improve with methotrexate, but enthesial and axial. So
Yes,
it is
sir.
an indication for non-conventional DMRDs even upfront in this
Yes, sir.
patient. Sulfasalazine we do try, but sulfasalazine is not very effective for skin involvement, and very axial also doubtfully
Axial.
effective. So there is an indication.
Yes,
Shweta, are we running out of time?
Yes, sir.
Arul, do you have
So,
anything
Can go on.
Yes, sir. If
concluding?
you want to close, yes, we can close.
No,
We can go on. We can go on for
We can
even
go
for
on.
one more hour. But we don't have time.
any expert advice on for the students how to improvise? Should
Yes, actually presentation is okay, but we need little more elaborate history taking and clinical examining.
Yes, sir.
Be little more. If you want to present it as a long case, we need a little more details. But here we have only short time. But in the exams, you will need a little more elaborate history and the clinical examining findings, so that your case sheet will have some marks, reasonable marks. So otherwise, yes.
yeah,
And the
I think
disease activity you have to include in the case sheet, disease activity measures and
Yes, sir.
the activity of the disease. How did you assess? All those things should be mentioned in the case sheet.
Arul, you are not clearly audible. You have to be a little louder.
Okay, sir.
yeah.
So in the case sheet, you have to include even the disease activity measure, which you use commonly. So before your treatment aspect.
Yes, sir.
Right. What are other factors you will look for in the management of psoriatic arthritis, apart from this musculoskeletal?
Also
Especially in
the skin.
psoriatic arthritis.
Yes, sir.
What
Skin
are the
and
comorbid? What are the comorbid conditions? So when you summarize the diagnosis, you have to include the comorbidities, especially in psoriatic arthritis.
yes, sir.
What are the comorbidities that are
Hypertension,
Yes.
hyperuricemia, dyslipidemia,
yes,
and
fatty liver?
yes, sir.
Fatty
Metabolic syndrome.
syndrome.
Metabolic syndrome includes everything. So almost everything which you had
Yes,
mentioned.
Yes.
Yes, sir.
So in the management aspect, you have to include those things also.
So if diagnosis should be clinical phenotypic diagnosis and functional diagnosis. You have to give them a functional class 1, 2, 3, 4. Somebody is bedridden coming in a wheelchair, you should say it's a class 4 function. Somebody is walking around, you can say class 1 or class 2. That is also important.
Yes,
So
the physiotherapy, you have to include physiotherapy also.
The therapy in the treatment, but in the diagnosis, functional class is important. So patient for psoriatic arthritis, whatever axial spondyloarthritis variant, psoriasis, comorbidities if any, functional class 2 will be your final complete diagnosis. That is better way of presenting in exam.
Yes, sir.
Yeah.
Okay.
Yeah, I think to conclude, I mean, it was excellent presentation. I mean, it really went through like a typical examination. And I think I should thank Dr. Arul and Dharmanand, especially Dr. Arul. I mean, literally putting the scene right into the examination. But I can say Dr. Anjana, she really performed fairly well. I mean, I don't take it as a discouraging point. I think you have to pick each of these points so that it helps you to improve. And also the others who have seen it to learn through this as if you have experienced as an exam-taking student. And also a few of the real-time points which are really going to be helpful for the freshers as well as the people who have worked for fairly long time in the rheumatology. I thank both the experts. Over to you, Dr. Shweta, for a conclusion.
Yes. As you said, yes, it's a very commendable discussion that happened. So me, like a student, I'm also a student. I learned a lot of things. So clinical discussion went really well. I think it will be helpful for all the students. Thank you, Dr. Arul, Rajamurugan, and Dr. Dharmanand, and Dr. Chandrasekhar. Thank you, Dr. Anjana, for a wonderful case discussion.
And thanks for all the participants too. I think
I would,
Thanks.
yes, sir. I would like to thank Chandrasekhar sir, Dharmanand sir, and Arul sir for giving me this opportunity to improve my clinical skills in the future. Thank you, sir. Thank you so much.
thank you. I think we can conclude the program. Thank you. Thanks.
Thank you, sir.
Thank you, sir. Thank you, sir.
Bye.